Hey everyone, let me know if you can see and or hear me. Hey everyone, thanks for joining me this afternoon special. 4 hours all the way. Yes, it's going to be a wonderful afternoon, I think. Unfortunately, you're keeping me from my administrative duties because I get to skip out on the faculty meeting, so this is a win-win for everyone, I think. How was the cardio exam? Hello, hello. Rough. That's sounds about right for cardio exam. It was interesting. I never want to have an interesting test. I like fair as my favorite objective or adjective for my exams. Guys like the video at least. I'm not sure what that means. Hello, hello. Oh my goodness, got 2 likes already. It's wonderful. I don't know if I mentioned, but I broke the 500 subscriber mark. So that was pretty fun for me. So I remember when I just got my 100, I think a couple of years ago, and was able to get my own like URL and stuff. So at this rate, by the year 2160, I'll hit 1,000 maybe. We shall see. So for my lifetime earnings from YouTube has currently been $0. So I'm doing pretty bad on that front. You could unlike the video. Don't do that, Peter. That would be very rude to do to your advisor. We still be streaming then. I will be a head in a jar by that point, I think. So maybe. Yeah, I wonder when you get the first play button. Probably like 10,000 subscribers, I would imagine. I don't know. I've never looked into it. I like the one on the hydraulic press channel when he got one and put it in the hydraulic press. It was pretty cool. That's true. We should all be so lucky to be head in a jar by 2130. That's exactly what I was thinking, Marley. I play a lot of the Fallout games, and so there's a lot of heads in jars there, so my main inspiration. Starting about a minute here, and if you have any questions, as always, put them up in the chat or on the sticky board, and I'll be sure to answer those. Exactly, bottle caps will go a long way there. Although I'm not sure who really has any bottle caps anymore. Most people don't drink from glass bottles, so we might be out of luck there. Although I do have a Fallout lunchbox in my office, so if you guys ever get to go check that out, which at this rate seems less and less likely, maybe you can come see it. I have a little Vault Tech bobblehead as well. Anyway, let's go ahead and get started here with the recording. Hello, everyone. I did have one question on the sticky board regarding the prescription assignment, which, if you don't recall, is due Friday. Sorry for the quick turnaround time. Yes, I do love Bethesda. And Microsoft just bought them out. How fun is that? That should be, I hope that's a good arrangement. Anyway, don't get me on the tangent of video games. I will be here all day, and we have 4 hours of lecture to get through. So, anywho, the question about the prescription assignment, which is due Friday. Again, I apologize about the quick turnaround time. My sticky board isn't showing the notes that would allow me to post. Have you had that issue before? There might be a button on the side here. I think if you can see this here, if you click that little down arrow, you should be able to find one. So try that out perhaps. Anyway, so someone was asking, do you want us to write 2 prescriptions for both ramipril and HCTZ, or use a combo drug which has both? Yes, I will leave it at that and leave the decision up to you. So there you go. All right. Let us switch gears. So just an FYI in terms of like the programming of the lectures here. So we have this lecture, and then we have the one on Friday, I believe, and then the test is on Monday. I don't think I'm going to have time to get through everything and also do a live review. So what I'm thinking about doing is go ahead and having a full lecture on Friday to get all that material done. And then I will also post up simultaneously me going through the Kahoot, and I will give you the link so you can actually do it with me. And then if you have questions afterwards, you can certainly email me. I'll still go through and kind of give my explanations for all the questions and everything, and that way, you get some sort of a facsimile of a live review, but you'll just have to email me questions that you have there. So just an FYI. And of course, I expect everyone to be here for the farm. If you want to dip out for the EpiBio after this, I don't blame you. 4 hours of me straight is a lot for anyone, and I do not begrudge you if you abandon me in that second 2-hour block. But regardless, show must go on. Getting into beta blockers, we talked about our diuretics. We got into our renin-angiotensin system inhibitors. We got into our calcium channel blockers. Now let's talk about our beta blockers. I know I've mentioned beta blockers a lot before, and we've talked about them briefly in terms of like ophthalmology. But let's talk about how they're going to be used for cardiovascular purposes. And you're going to find beta blockers, while they can be really good drugs for certain indications, frequently aren't going to be first line for hypertension. Just like, and someone actually asked me this question via email, they were like, well, wait a second, you said calcium channel blockers can be used for, non-dihydropyridines can be used for blood pressure, for hypertension, but, Dr. O's lecture said not to use them for that. That's correct. In a lot of cases, there are very few individuals who I would start out by using verapamil as like a go-to first-line antihypertensive. The difference, though, is that frequently your choice of antihypertensives is going to be based off of other comorbid conditions. So, for instance, if I had someone who had like AFib and I needed them to be under a form of rate control to keep their atria from kind of just fluttering, fibrillating away, I guess fibrillating, I don't know if that's a verb actually, but from it just kind of beating away, you can put someone on something that kind of blocks AV nodal conduction to prevent the ventricles from trying to kind of go out of control there. So something like verapamil might be a perfectly good reason for that, or a perfectly good use for that drug. You get the side benefits of it also helping out the blood pressure. And what you're going to find in a lot of patients is that one med's not going to be enough to manage the blood pressure on its own. Frequently, you need 2 or more medications there. But this is going to be the similar case for beta blockers, to where you don't see them necessarily being used as a first line sort of medication here for hypertension, but they could be useful for a lot of other purposes, as we're going to see here. So what do they do? Well, they're going to be blocking beta receptors, as the name sort of implies here. So they're competitive antagonists at the beta-1 receptor. So acutely what you're going to see is that they will have a decrease in cardiac output because you're slowing down the heart rate. You also have some decrease in contractility. And then as a result, you actually end up getting like a reflex increase in TPR, right? Because remember, your cardiovascular system wants to keep a balance there. If cardiac output goes down, then TPR needs to go up in order to keep everything sort of at equilibrium. Just like what we saw with the dihydropyridines, with those dropping TPR pretty significantly, you end up seeing an uptake of, or a increase in cardiac output as result, or seen with tachycardia, right? So that's the compensatory mechanism there. And this is actually a problem too, because a lot of like young people are not good candidates for beta blockers, because this actually impairs their exercise tolerance, right? Because if you're trying to run somewhere, if you want to run a mile, for instance, which I don't personally recommend unless being chased by something, you can end up finding that if your heart rate is not able to pick up the pace in order to meet the oxygen demands imposed by the skeletal muscle, you can find that they get exercise intolerance. They get winded very easily, get tired very quickly. So that's why you're going to see in some cases not great from that standpoint. Although in some patients we'll actually see it improves exercise tolerance. I'll talk about why that is a little later. But looking at this also, we can find there's other ancillary purposes for using the beta blockers other than just what's on the heart, right? And remember, beta-1 receptors are predominantly what's going to be there on the heart. We can also find, though, that other places, too, that by blocking beta-1 receptors, you actually can decrease renin release. Remember that the sympathetic nervous system was one of the influencers on renin release, and if you can block that by blocking the beta-1 receptors, you get less renin, and thus you get less angiotensin 2 ultimately being produced, which is good. So you can see how this could work in conjunction perhaps with something working on the RAS system in those cases there. Although there could be some other problems too. So for instance, a lot of our beta blockers, we're going to talk about them as either being selective or non-selective. And when I say selective, it means they're going to be selective for the beta-1 receptor versus non-selective will affect both beta-1 and beta-2. There are beta-3 receptors, but there's not a whole lot of drugs that interact with that, or really any that I can think of that are used clinically. Beta-3 is seen a lot with like lipolysis and some influences on that, but I won't really get into that in this lecture here. But the problem that you're going to see with non-competitive or non-selective beta blockers affecting the beta-2 receptors is that it can affect those beta-2 receptors in the lungs, right? Remember, you have beta-1 heart and you have beta-2 lungs. Some people remember it that way. And so by doing that, you can actually block the bronchial smooth muscle relaxation that is normally induced by activating beta-2 receptors. What that means is that for some people who have reactive airway disease or they have a history of asthma, you may not want to use a non-selective beta blocker because it can result in bronchospasm. Or potentially, say for instance, like I have an asthma attack, and I have a beta blocker on board and they're blocking up all my beta-2 receptors. Well, the mainstay of therapy for asthma is a beta-2 agonist like albuterol. And if those receptors are blocked up, that drug is not going to be able to work as well. So there can be some issues there. And so that's going to help us to choose the appropriate drug based off of comorbid conditions and past medical histories and all that kind of stuff, right? So some other effects of the beta blockers is you're going to see that we'll also end up getting decreases in norepinephrine release by blocking some of these presynaptic beta-2 receptors. Has something to do with the auto feedback sort of process that these nerves can undergo. And then overall, you're going to get a decrease in sympathetic nervous system activity. So what that means is, in terms of CNS effects, this is going to be more primarily for drugs that have like a higher lipid solubility. And you're going to have a higher effect on being able to cross that blood-brain barrier and being able to affect the CNS. So what that means is that in some cases, for really lipophilic ones, which we'll see some comparisons in a few charts in a moment, you can see things like depression can happen here because overall you're kind of decreasing sort of that stimulating effect of the sympathetic nervous system, but also can actually have some effects on migraine headaches. And so when we talk about neuro stuff next semester, you'll see that we can use beta blockers as a preventative for migraines. And then you also get this altered baroreceptor reflex response, which is also important for blood pressure concerns. Remember that over time, while your body does like homeostasis, it can develop, like a new normal, kind of like how we're in a new normal now with COVID, right? But what we can see that is with having high pressure for a long period of time, like normally you think a normal blood pressure is like 120/80. But if you're living at like 160/95 or something for years, your body just gets used to that, and that's part of the altered baroreceptor reflex response. And so if you tried to dip the blood pressure underneath that by introducing an ACE inhibitor or something, the body's going to resist that because it says, hey, there's too little pressure here, let's try to bump it back up. And so you can end up seeing that by introducing a beta blocker, you can help to reset that reflex response over time, which is kind of handy. Shelby's asking, so it decreases migraines and increased depression with beta blockers. That's a good question. So yes, it will increase depression potentially. And even with like certain elderly individuals, you can see like worsened dementia. You can see nightmares that can pop up with these really lipophilic ones. What's actually kind of funny is that, not funny, I guess, not funny, haha, but funny, that's kind of interesting, is that acutely beta blockers can actually cause migraines for people who are predisposed to them, but chronically we can use them to actually prevent migraines. So it's kind of a yes and no sort of situation there, but don't worry too much about that. We'll talk more about that extensively in the neuro section later on. So how do we choose which beta blockers we like for our patients there. The number one thing we're going to consider here, this is probably, I'm going to bold this because it's really important, is selectivity. Does it block just beta 1 receptors? Does it block beta 1 and beta 2? Does it have some ancillary blocking abilities, which we'll see in just a moment here? Secondary concern would be things like metabolism. So for instance, if I had someone with poor renal function, then maybe something that goes through higher hepatic metabolism would be a better one, right? Versus if I had someone who had poor liver function, maybe something that was more renally eliminated might be a better option there. So it really just depends. Yeah, so Jonathan, yeah, they help to reset the set point. They help to reset what that normal should be for them. So that way, instead of it's like 160/95, it goes back down to like 130/80 or something like that, right? So anyway, so that's also a concern. Clinically, it doesn't come up as often because most of the time you're going to be titrating your dose to effect anyway to see how they're going to respond to it. But that could be a concern there. What's interesting though, we actually have what we call kind of like third generation beta blockers too, and so these are neat because they have additional properties that sort of help out with their antihypertensive effects and some other ancillary effects. So for instance, some of them can help out with NO production, which is nitric oxide, which is not nitrous oxide, that's a little different, right? But nitric oxide production, which can be vasodilatory, because this actually helps out with the muscle relaxant effects that you see with things like nitroglycerin, which we'll talk about at a later time. There can be things like alpha-1 antagonism, which we know that if we block alpha-1 receptors, that causes the vessels to dilate, because remember, alpha-1 causes constriction when you're agonizing it. When you're antagonizing it, it would cause dilation to occur there. And similarly, actually, beta-2 agonism, just like we talked about at the end of last semester, is that beta 2, when it's activated, typically causes smooth muscle relaxation. That's why it does that in the lungs to cause bronchorelaxation. It can do that too in the blood vessels as well, right? That can be an additional benefit. You know, if you block calcium entry, we saw that that can have an effect on smooth muscle constriction there. Just to clarify, the metabolism is hepatic. It depends on which ones we're looking at. So some of them will be more renally eliminated. Some of them will be more hepatically eliminated. I'll show you that in the table in just a few moments here. Some can have effects on potassium channels. This can be important for some of this antiarrhythmic activity, as we'll see in a little bit. And then some can have some antioxidant effects, which may be beneficial for things like atherosclerosis and things like that, where there's a lot of inflammation. So here's what I want to show you in terms of the first generation beta blockers. These are the non-selective ones. You know, this is sort of a pre-populated table here. The main things I want to point out for you is don't worry so much about the membrane stabilizing effect. This has more to do with antiarrhythmic activity, which I don't want to get into too much right now. We'll have it later section. We'll talk specifically about that. And then there's something called ISA, or I think of the word. It's intrinsic sympathomimetic activity. Sorry about that. I had a brain fart in the afternoon. So intrinsic sympathomimetic activity. Again, clinically, this does not come up super often here, but what does, I think, is important is to understand the lipid solubility. So the higher the lipid solubility is, the more likely it is to get into the CNS and cause things like depression, cause things like nightmares in elderly individuals, you know, things like that. So those would be things you want to be maybe considerate of, or maybe these would be better for things like migraine prevention, for instance. Like propranolol is a kind of a prototypical like high lipid solubility sort of beta blocker here. Now, if you note underneath the names here, I've put either goes through renal elimination or hepatic metabolism. I can probably tell you on a test right now. I'm not going to ask you which ones these go through, because again, clinically, this is not, I'm not thinking about this as much as I would be, for instance, with like an antibiotic. Antibiotics, that stuff is super important because you can really screw things up if you're giving too much or too often and causing a lot of organ toxicity. This is less likely because, again, what are you going to be monitoring for when you give someone a beta blocker? Well, probably their heart rate and blood pressure. And so you can kind of monitor and adjust your dose to sort of fit around that. But if, you know, for your edification, it's there. So again, these are non-selective. They're going to be affecting both beta 1 and beta 2. A handy tip that will help some people remember which ones are which. And again, this only applies to our first and second generation ones. If the first, and again, you can always tell a beta blocker because it ends with O, LOL, right? Which is not very funny. I'm not laughing out loud by any means, but if the letters, or the first letter of the name starts with an N through Z, so anywhere from N to Z, it's going to be a non-selective beta blocker, right? So nadolol, penbutolol, pendolol, propranolol, sotalol, timolol, those are all non-selective. If it's A through M, those are going to be selective. meaning they're going to be selective for the beta 1 receptor. The exceptions to that are going to be the third gens. They don't really fit into that, so you'll just have to kind of know which ones are third gen, as we'll see here in just a moment, okay? Getting into the selective ones, which again are going to be focusing on just blocking beta 1 receptors specifically. Now again, selectivity can kind of go out the window, especially as you drive doses up really high. But for the most part, these would be, say you had a patient with a history of asthma, these would be much safer to use in those patients than would be a non-selective beta blocker. I feel much more comfortable about someone taking atenolol, for instance, if they had a history of reactive airway disease, COPD, asthma, they're on now albuterol inhaler for bronchospasm, things like that. I feel much better if they're on one of these medications here, okay? Again, you can recognize them as A through M, going to include all of those, right? So acebutolol, atenolol, bisoprolol, esmolol, and then metoprolol. So again, none of these really have high lipid solubility. A lot of them have, some renal elimination associated with it. So, a lot of renal clearance here. One that I want to point out here is that we do have some that are available IV. Most of these are orally administered medications here, but for instance, if you've ever worked in like an ER or an ICU, you might have seen something like esmolol being used before, called Brevibloc. And actually, sometimes the half-life of the drugs can make a difference in terms of how you use them. So for instance, Brevibloc sounds like it's a short, brief block, and so that's actually why it got the brand name it does, because it's really short acting. And so this is nice because I can actually have a patient who comes in, say they're tachycardic, hypertensive, I can give them esmolol as a continuous infusion, and that way I can dose it to where if their blood pressure is still too high, heart rate's still too high, I can just dial up the dose. And if their blood pressure or heart rate gets too low, dial down the dose, and that way it's very titratable. Long-acting medications are not going to be like that. They're much more difficult to control, or it takes a longer time for you to make adjustments. Short-acting meds, though, very quick to do so. Anyway, here are the third generation ones. Again, the main points to take away are being able to recognize which ones are going to be third gen, and then also looking at some of the other actions that they have. And this is why they may be beneficial for certain conditions like CHF, for instance, or some other things. So for instance, like cardiolol, which we saw and back in glaucoma, that was Ocupress, that has some additional benefits of things like being a beta-2 agonist in addition to blocking beta-1 receptors, right? It also has some nitric oxide stimulating activity, which can be vasodilatory. The more common ones you're probably going to run into, though, are going to be carvedilol, labetalol, and betaxolol. And so betaxolol, you can see some oral usage there, again, having some additional benefits of vasodilation and calcium entry blocking effects. That again, that can be vasodilatory. The two I see used most frequently, though, for sure out of this category is going to be labetalol and carvedilol. Carvedilol is really nice because it actually has some alpha-1 blockade, similar to labetalol, such that it's able to get some additional blood pressure lowering effects in addition to lowering the heart rate as well. And carvedilol, you actually see it recommended for CHF a lot because it's thought to have some antioxidant and some anti-proliferative effects, which are thought to influence things like cardiovascular disease and things like that. So we talk about CHF specifically. We'll talk about which drugs are approved for that in terms of like improving mortality and whatnot. So those are the main differences there. Labetalol is another good one to use like for short-term control of heart rate and blood pressure. So we use this a lot in ERs and ICUs to help get that under control. So for instance, you may have like a PRN order for labetalol. It says give so many ever milligrams, Q6 hours PRN for heart rate above this amount and blood pressure above this, and that way it can be useful to help control the cardiovascular system in that way. So anyway, so what are we going to use this for? What are our indications? Hypertension, and like I mentioned, not recommended first line for hypertension. This is typically an add-on medication for patients who are maybe on other medications already. This is a decent one to consider adding on if they have another compelling indication to do so. So who does this work best in? Typically, if you have someone who's in a higher sort of sympathetic sort of tone state, right? So if they have a resting sympathetic nervous system that's kind of elevated, maybe due to something like overactive adrenal glands or something like that, or SNS from the central circulation or central nervous system is kind of upregulated. Here you're going to find this is good because if they have like resting tachycardia, they have a lot of catecholamines coming around from the adrenal glands and things like that, high renin levels. This is good for them. The downside, though, is going to be the common issue with limiting exercise, right? So again, you can get very fatigued. Very similar to how I mentioned altitude sickness with harmonic anhydrase inhibitors. I remember one time I went to Colorado for like a conference and I walked up like 2 flights of stairs and I almost passed out at the top of it because I wasn't used to having such low oxygen pressure there. Kind of the same thing happens with a beta blocker. The heart just can't keep up and can't pump that oxygen-rich blood around. So that can be an issue there. We'll still see it has some use in the elderly patients, but again, not going to be first line. This is an add-on medication for the most part. And again, you can see some of the mechanisms here. You can see some of the changes that happen which lead to its sort of chronic beneficial effects. So for instance, if you were to look at, say, mean arterial pressure, you were looking at cardiac output and then total peripheral resistance. You can kind of look at the change here on the y-axis, and then on the x-axis here, notice we have sort of the acute phase and then we have the chronic phase. So we kind of look at the differences and effects here with administration of a beta blocker. So don't worry about the ISA ones. I don't really care about those so much at this point. I want you to focus more so on the actual beta blocking effects of it. So what you can notice here with mean arterial pressure when applying a beta blocker to most patients, you're going to see there's not a huge difference here. And you're like, well, how can that be? Because I thought that we're lowering heart rate. You know, why are we not seeing any changes there? A lot of that is due to the reflexive mechanisms of the beta blockers, right? So what we can see here is that as cardiac output certainly goes down, TPR goes up. So you may see that you have, especially if like outpatient management, things like that, you're not going to have a huge change in mean arterial pressure right off the bat. What happens over time, though, is you have things like the decreased sympathetic nervous system effects, you have the altered barrel reflexes, you have angiotensin II levels go down, and so chronically you're going to find that, yeah, mean arterial pressure actually does come down because cardiac output stays low because you're still blocking all those beta receptors, but then you're going to see the TPR actually then comes down as well. So that's kind of the benefit here of beta blockers, is that chronically they can be beneficial for helping control blood pressure. They may not be the best option right off the bat, though. But if I had someone who was like really in a hypercatecholamine sort of state, like, you know, they've taken a bunch of amphetamines or something, for instance, you know, this may be useful to help get things like heart rate down, for instance. So what are some other indications? We talked about their use in glaucoma and how they help decrease aqueous humor production. For migraine prophylaxis can be also useful. We'll talk about this in neuro more in depth, but basically a lot of migraines are mediated based off of vasodilation, basically increasing pressure up in the CNS. Can actually cause impingement on things like the trigeminal nerves and whatnot, and can lead to those migraines. And so if you can regulate those blood vessels in terms of how much they are able to dilate or constrict with using something like a beta blocker, that can help to mitigate some of those migraines from happening. So it's a preventative. It doesn't actually treat it, because acutely, if you start at full dose, it can actually make the headache worse in a lot of cases there. So what are some other cases we can use this? Well, hyperthyroidism is a good one, because you know that if you're hyperthyroid, you're going to have a very hyperadrenergic sort of state there. Let's see. Some people have used beta blockers in static apnea for free diving to beat world records. It's considered doping cheating. Yeah, I can imagine that's interesting. Maybe you're trying to, regulate your blood flow a little bit and try to hold off. Drop your cardiac output somewhat. It's pretty interesting. I don't know if I would want to do that, but yeah, it definitely sounds like a cheat code. I'll tell you about performance-enhancing effects of beta blockers here in just a moment, though. It's a good transition there. Andrew is saying, I used to take metoprolol for inappropriate tachycardia and had to stop after a couple of years because it started drastically dropping my blood pressure. There you go, right? So I think you can kind of see the chronic effects and the acute effects there for sure. So that's pretty interesting, Andrea. Anyway, so in terms of hyperthyroidism, or if you're having like thyrotoxicosis, think about someone who's like really hyperthyroid, they're gonna be sweating and they're tachycardic and they're hypertensive. Tremulous, this really helps to decrease a lot of those symptoms and help out with that. So it'll drop the heart rate, it'll get the tremor under control. Remember, tremor is frequently as a result of beta 2 activation on skeletal muscle that causes it to become kind of hypersensitive, and that's why you get that kind of tremulous sort of effects there. However, you may see, an acute bump in blood pressure. A lot of it has to do with issues like stroke volume being decreased, so then you can end up having some compensatory mechanisms that happen there. So you do sometimes have to use this with another drug in order to kind of offset that. But the interesting thing is especially like propranolol, this is an interesting effect. You can actually inhibit peripheral conversion of T4 to T3. And we'll talk more about this when we get into endocrinology next semester, but T3 is a more active form. So if you can block that conversion, it helps to mitigate some of those effects there. So you may see that occasionally. Now, what are some of the big uses for beta blockers? Well, angina is a really big one because it helps to decrease myocardial oxygen demand. because you're slowing down the heart rate, so it doesn't require as much oxygen in order to keep it running, which again is impaired with people who have angina, for instance. So we're going to talk about this a lot more in the next section, so don't worry about that too much right now. Just know that it decreases oxygen demand and can help to prevent anginal symptoms from happening here, or it will give the chance for a patient to be more active before anginal symptoms will develop, right? So kind of in this case here, it actually can improve their exercise tolerance because they don't get anginal symptoms as quickly with basic activity and things like that. So just be aware of that. We'll talk about this a little bit more in detail in the next PowerPoint section. We also use these very frequently in acute myocardial infarctions. So you're going to see here that this actually improves mortality. It's actually going to drop mortality by initiating beta blockers really early on after an MI or during an MI, right? Because again, MIs can kind of present different ways. Maybe they're tachycardic, maybe they're bradycardic. It just depends. If they're bradycardic, obviously you don't want to start a beta blocker. That's just going to worsen things. But they come in and they're tachycardic, you can start a beta blocker right away, basically. And so what this is going to do is it helps protect the ischemic myocardium from that norepi and epi. Remember, this tissue has been starved of oxygen and starting to kind of die off a little bit, and so because of that, if you then sort of overstimulate with things like norepi, it can kind of accelerate that sort of oxidative damage that happens and can kill off more of that tissue there. And also by decreasing oxygen demand and decreasing contractility, this also helps to prevent things like recurrent MI. So that's a really big benefit there. And in fact, most patients, unless they have a really strong contraindication, after MI, they need to be on a beta blocker. That's like one of the absolute gotta have drugs on there. Okay. These can also be useful for supraventricular arrhythmias because they help to actually slow down AV nodal conduction. So they can actually slow down if you had like an arrhythmia that was, say, situated in the atria, sending down very rapid signals into the ventricles. You can slow that down by using a beta blocker. Very similar to how the non-dihydropyridines can do the same thing, either diltiazem or verapamil. And so in fact, if I have a patient who's in like SVT and they come into the ER and they're not responsive to something like Valsalva maneuvers and things like that, you could use either a beta blocker or a calcium channel blocker, right? Either one of those would be good for helping to slow down the heart rate. Or if something like adenosine failed, which we'll talk about later. But anyway, also another interesting indication here is acute panic attacks. And so what you can see here is if you imagine a person experiencing a panic attack, maybe you felt this before like the cardio test, or maybe you'll feel this Monday. But those symptoms of anxiety, the physical manifestations, a lot of it are due to the effect of the sympathetic nervous system, right? You're in a fight or flight response there. Sweating, tachycardic, hypertensive, all those things. Beta blockers can really help out with that. It can decrease the tremulousness. They can decrease the heart rate so you don't feel those palpitations. Can really help out a lot with that. And even just benign essential tremor can be affected by this as well. So it kind of makes sense why this would work for like panic-like symptoms additionally. So not only can you use it for that, which probably isn't like first line for acute panic attacks, but frequently, I don't know if I put it on the slide here, you can also use it for things like performance anxiety. So for instance, if you had a big presentation that you wanted to give and you need to get up in front of a bunch of physicians and other PAs to give this presentation, you'd probably be pretty nervous. Most people are pretty scared of public speaking. I know I was for a really long time until I, basically do it for a living. And so it's one of those things where if you can decrease those nervous symptoms, you will feel more confident typically and you can perform better. Or it's like hard to play an instrument if you have really shaky hands, for instance. So this helps out to decrease that quite a bit. I know some patients, or not some patients, I had some fellow classmates. This was really one of my big aggravating points when I was in school. So I used to be a young man, and when I was in school, I was very concerned about my grades and I always want to get straight A's and all this stuff, like some of you may be right now. I always remember we had this class called pharmacotherapy, where basically there was like, at my campus, we were up in Jacksonville, there was 50 of us in the class, and we would have a case, someone would be down acting as the facilitator was acting as sort of like the patient, and they would basically do an interview. So we would call random people, go down to an interview, and then the next week we'd come back with a soap note ready and talk about our plan. And anytime you got called on, it was very nerve-wracking because it was always at random, always a very tense sort of experience waiting to see who they're going to call on next. And I had heard that some of my classmates were actually using propranolol to help out with their nervous symptoms to get those under control. So they actually performed better and got a better grade than what I did, because when I got there, I was like super nervous and shaking, and it was not a great scene. So I was like, they're using performance enhancing drugs. How dare they? I was pretty incensed for a while, then I kind of got over it because grades don't really matter after a while. C's get degrees, as they say, right? Anyway, yeah, Shelby, I need to get a prescription for that this semester. It could certainly help. I imagine some of you might have benefited from that from your OSCE, right? So I'm not providing any medical advice, but I know some people that is something they may get a prescription for because of that indication there. So just something that you'll see it used for occasionally for like a PRN beta blocker prescription. That's likely what it would be for. Another really compelling indication for a patient to be on a beta blocker is going to be for congestive heart failure, chronic heart failure. There's 3 though that you need to be on. So either carvedilol, metoprolol succinate, or bisoprolol. Those are kind of the 3 main ones that are indicated for CHF specifically. Carvedilol being a 3rd-gen beta blocking agent, metoprolol and bisoprolol being selective beta 1 blocking agents there, right? Now, I notice most of the time, like on tests and things like that, I frequently don't put salt forms on the exam because frequently it doesn't matter, right? You don't really need to know whether it's, metoprolol hydrochloride or something like that. But specifically for metoprolol, this does matter, right? So this is something I want you to kind of keep an eye on. So there's 2 main forms of metoprolol. There's metoprolol tartrate and there's metoprolol succinate. The tartrate is the short-acting form, and the succinate is the long-acting form, okay? So if you see like Toprol XL, that's going to be the extended release formation. You only take 1 time a day, versus something like metoprolol tartrate, it'd only be like twice a day, for instance, because shorter acting. The way I remember this is I think about hard candies you have to suck on for a while. They last a lot longer than something like, chocolate would. So I think about metoprolol succinate, sucking on that medication for a while, it's going to last a long time, Imagine like a Werther's Original versus like a Snickers. Like Snickers has gone super fast. Werther's Original might stick around for a lot. But anyway, so that's a really important distinction to make there. Unfortunately, I don't have any chocolate to hand out to you, but yes, you can think about that if it makes it your time in this lecture a little bit better. But the nice thing about these, it actually reduces mortality pretty significantly. Even over a short time span of even 3 years, you can see significant reductions. Because frequently, again, what's oftentimes something that led to the CHF in the first place? Well, it could have been an MI, right? So again, it makes sense that CHF, MI would be 2 indications where they really need to be on a beta blocker. What's interesting, though, is that beta blockers used to be contraindicated for CHF. And it makes sense because you think you have someone with like poor LV function, for instance. If you were to drop that down by giving a beta blocker, then that could lead to a CHF exacerbation. That sounds kind of counterintuitive. But what we find is that over the long run, that by decreasing cardiac output, we can end up seeing that overall, or by decreasing the effects of the sympathetic nervous system on the heart there, you actually end up getting improved cardiac output because you're allowing for the heart to have longer fill times, you're decreasing TPR so the heart doesn't have as much afterload to pump against. And so overall, what you can find is that by starting really low dose, and usually you're starting this in the hospital even because they can be so sensitive, and gradually titrating up, they do have really good effects on the heart in the long run. And so be careful with this because, again, if you go full blast beta blocker and someone's CHF, you're going to put them in the hospital for an exacerbation. But if you can, again, titrate it very slowly, you can eventually get them to a point there where they're getting all these benefits of having increased cardiac output and decreased TPR, which is counterintuitive to what you would think with a beta blocker. But again, it depends on the disease state they have. So moving on to the adverse effects here. So bronchoconstriction is going to be a big one. So you want to think about inducing asthma exacerbations or perhaps making things like beta 2 agonists work less well. Things like, COPD patients can be included with this as well. So you want to be cautious here and use beta 1 selective agents. So like metoprolol, atenolol, any of those are fine. I would not use a non-selective beta blocker on one of these type of patients, okay? Again, be aware of the cardiodepressive actions here. So again, for some patients, you could worsen CHF if you kind of go too strong on the beta blockers early on. If they have bradycardia, this is going to worsen that, right? So you want to be careful about inducing AV block and whatnot. So again, if they already have a history of bradycardia or AV block, this may not be a great set of drugs to start out with, okay? Interestingly, you can also see some issues of disturbed glucose metabolism, right? I say disturbed because it depends on which one you're dealing with, type 1 or type 2 diabetic patients. You can either run into issues of hypoglycemia or issues of hyperglycemia. It seems kind of counterintuitive, but I'll walk you through it. With type 1 diabetic patients, remember, they have an issue where they don't produce any of their own insulin, right? And so what they end up running into problems, though, is that if they hit a point where they are taking exogenous insulin, and they are maybe getting low, right? Or maybe they forgot to eat or something like that and they're getting low. Frequently, what the body's going to do to try to get that blood sugar back up is by activating glycogenolysis and gluconeogenesis in the liver. How does that happen? Well, it's through the sympathetic nervous system activating those beta receptors. And so if you block that, you can block the glycogenolysis, leading to prolonged hypoglycemia. Not only that, but you can mask the symptoms of hypoglycemia as well, right? Remember, how do you feel when you're hypoglycemic? I don't know if anyone's ever felt that before. If you feel really hangry, you get really anxious, you might be sweating some, you feel like your heart's racing, you're tremulous. You know, it's a lot of those symptoms that are masked by the beta blockers, just like we would use beta blockers to treat those symptoms you would experience during a public speaking event or some sort of public event, right? So that's something to be really cautious with and warn patients, hey, you know, be careful. You may not feel like you would normally feel while hypoglycemic, so you need to be checking your blood sugar more regularly and things like that. For type 2 patients here, you can actually find that they can produce their own insulin. It's just they have really high insulin resistance here, but you can actually find that beta blockers will decrease insulin release, and that can again exacerbate their hyperglycemia. So that can be more difficult to control. You know, they may need more insulin, or they may need to go up on their doses of medications to fix that. So not only that, but again, they can mask the signs and symptoms of hypoglycemia. And a lot of the side effects of diabetic medications is hypoglycemia. So you gotta be really careful with those patients, okay? Okay. Some other things too is you can have impaired peripheral circulation. And so, for instance, you can exacerbate things like Raynaud's phenomenon. You can have skeletal muscle fatigue. Again, if you're decreasing blood flow to those areas there, and you can even have worsened peripheral artery disease. So you do want to be cautious. You'll be relatively contraindicated in patients like this. A lot of this is due more to blocking the beta 2 receptors on those blood vessels and preventing them from dilating. Right. So they can't dilate effectively. They can't send blood to where it's needed. And that's where you can get things like the intermittent claudication there. Right. And this is an important point here as well, sudden withdrawal syndrome. Remember that the body likes equilibrium, it likes homeostasis. So if you have a beta blocker on chronically, you're blocking all those receptors. The cells are saying we're not getting enough activation. Let's upregulate the number that we have available to us. And so they're going to upregulate. There's more beta receptors there now, which are now also being blocked, right? Well, if you take away that beta blocker all of a sudden and kind of go off of it cold turkey, you have much more activation of those beta receptors. Imagine on the heart, you upregulate all those beta 1 receptors and then you remove the beta blocker. Now all that norepi and epinephrine can really affect that quite strongly now because the cells are much more sensitive. And that can actually induce MI, things like that. Really big increases in blood pressure. So you got to be careful. Make sure they're taking it consistently. Make sure they're slowly withdrawing off of it if that's going to be the plan for them. Okay. I mentioned with the CNS effects, this is much more likely with the highly lipid soluble agents. I always think about like Pindolol and propranolol as being kind of the big ones here. Can worsen depression, can cause really vivid dreams, especially in elderly patients. And so the lipid solubility is what's really increasing the symptoms here. So using something, if I had like an elderly patient and I was worried and they had like dementia or something, I would use something more water soluble that had less lipid solubility, such that way it would not cause, less likely to cause a lot of these CNS symptoms there, right? Not to say it wouldn't cause it, but say less likely. And you can have some effects of elevated triglycerides, but again, a lot of these patients are going to be on lipid-lowering agents anyway. If they have cardiovascular disease, so you know that's probably under control anyway, hopefully. So in terms of drug interactions, the biggest thing you're going to find is a lot of pharmacodynamic interactions in the situation where if you're taking other cardioactive medications, you can see really big synergistic effects here. So for instance, if I were to combine a beta blocker plus a non-dihydropyridine, again, clinically, you would never do this. I don't know a single patient who would actually warrant being on both a non-dihydropyridine plus a beta blocker. But you could see, imagine someone mixed it up and accidentally gave both. Big drops in blood pressure, big drops in heart rate and contractility. So that way you'd have to be really careful here. On the other hand, though, there could be additional benefits. Say someone was on amlodipine, a dihydropyridine that's working mainly on the blood vessels, but they were still having some issues with cardiac output. I could then put them on a beta blocker and actually get some good synergy there. So it's not uncommon to see a dihydropyridine plus a beta blocker. It is very unlikely, and it's likely an error if you see a non-DHP like verapamil plus a beta blocker. Okay, just as a general caveat. There's some other meds too, like our alpha 2. I should actually say agonist. I don't know why I'm putting that on there. That's incorrect, right? Alpha 2 agonist. We'll talk about clonidine in just a little bit later. But again, anything dropping blood pressure, anything dropping heart rate can be synergistic with beta blockers. So you really got to make sure you're monitoring for that. Make sure patients are not going to be worried about orthostatic hypotension, syncope, things like that, right? Okay, so those are the beta blockers. Now let's switch gears and let's talk about our vascular smooth muscle relaxants and also talk about some of our alpha blockers here. So first off, I want to talk about alpha-1 adrenergic antagonists, right? So these are basically just blocking the alpha-1 receptors to cause direct vasodilation. If I remove the effect of norepi and epi on those alpha-1 receptors on the vascular smooth muscle, they dilate, right? So pressure is going to go down. Reduction in TPR is the main effect here. But remember, as I decrease TPR, I'm going to get a reflex increase in heart rate, okay? Because again, they want to balance each other out in terms of systemic vascular resistance versus cardiac output. So if TPR goes down, cardiac output's going to go up. TPR goes down, cardiac output's going to go up, right? So this can be a problem because if you have a patient who's maybe prone to things like MI and they don't need that big increase in oxygen demand by the heart, this could be a bad drug for them because that increase in heart rate could exacerbate that problem. So you can kind of think about the clinical activity of the alpha-1 antagonist similar to the DHPs. So things like amlodipine and isradipine and things like that, okay? Because they both have direct vasodilatory effects due to this one, just due to alpha-1 blockade. So the first one here, we have prazosin. Some people say prazosin. I don't really care which one you say. This is going to be a selective alpha-1 antagonist. You may get some additional benefits of lowering things like LDL, but this is not the main clinical purpose here. And again, these are not used by themselves for blood pressure management because their effects are very minimal because of a lot of the reflex compensatory mechanisms, right? Because you have the increase in the renin-angiotensin system. This limits how effective these are by themselves. So they're usually used in combination with like beta blockers or diuretics, but these are like third, fourth line kind of agents here. Now, the biggest problems you're going to see with these is going to be the orthostatic hypotension, especially in elderly patients who've sort of lost a lot of that homeostatic sort of capability when going from a laying down or sitting to standing position. That can be really tough for them. And if you have these vessels that are wide open, they're not going to be able to pump enough blood to the brain, and they can syncopize, fall, break a hip, and now all of a sudden they're disabled for the rest of their lives, right? That's the things you want to avoid. To go along with that, a lot of postural dizziness, which can lead to fatigue and headache and drowsiness, all that stuff. So you want to be really careful with those patients. Elderly patients, these are not going to be the best medication for them, as it turns out, okay? As I mentioned, you get that mild reflex tachycardia. You also see a lot of increase in those compensatory mechanisms, as I mentioned, which can mean increased renin, increased sodium and water retention there. And of course, impotence is going to be another problem there. If you can't regulate penile blood flow effectively because these vessels are all dilated all over the place, that's going to be a problem. And again, sexual dysfunction is a common side effect of most antihypertensive drugs. Probably least likely with the renin-angiotensin system inhibitors like ACE inhibitors and ARBs, but for most everything else, it can be a problem. In terms of indications here, again, mostly this is going to be more of a pharmacodynamic sort of thing here. So again, be cautious in patients who might be on other medications that can enhance postural hypotension, right? So for instance, if I have someone who's on prazosin and their alpha-1 receptors are blocked and their vessels are wide open, and then they are also on a beta blocker and they can't even mount that tachycardic response to overcome that, syncope is very, very likely. So again, be careful who you're going to be using this in. Similar effects with NSAIDs attenuating the response, just like most other things we mentioned there. And then, of course, be careful in cardiac and renal failure because it can lead to kind of exaggerated effects. Other ones we have that are very similar to this include terazosin and doxazosin. Very similar effects there. You can kind of lump them all together in terms of what they're being used for. Mostly, you'll see them used as adjuncts for hypertension. Or you may actually see this being used for benign prostatic hyperplasia. And you're like, well, why would you use it for BPH? And we'll get into this in the urinary section, the GU section next semester. But it has to do with the alpha receptors that reside on the prostate. They can actually squeeze down and impinge the urethra. If you can block that, you can actually allow the prostate to relax and allow for better urinary flow to occur there. So that's why we end up seeing that. The ones that have a longer half-life tend to be a little bit better in terms of like the postural hypotension because you don't get really like big peak dose effects. So longer half-life is typically a little bit safer for these patients here. You could get even more specific, and so I just mentioned this one briefly. We'll see this much more so in the GU section next semester, but for instance, like tamsulosin, which has the brand name of Flomax, which I mean, it tells you exactly in the name exactly what it does. It maximizes your flow, right? This is specific for the prostate because it actually affects a subtype of alpha-1 receptors called alpha-1A. And so you used to have an old name, but alpha 1A, if you can block that specifically, it's nice because it just affects the prostate and really doesn't affect the rest of the vasculature. Meaning risk of things like hypotension and dizziness is much less than you would see with just a broad alpha 1 blocking agent there. So again, you can see different flavors depending which subtypes of receptors you're actually affecting there, which is kind of interesting. Okay, so that's the alpha 1 blockers. Now I want to talk about our central sympatholytics. And so just based off the name, what do you think that means? Well, it's working from the central nervous system to decrease sympathetic outflow. Okay, so what might you expect to see in terms of the cardiovascular effects? So I'm decreasing the activity of norepinephrine body-wide. Well, I can expect to see things like decreases in blood pressure, decreases in heart rate overall, and also centrally, you're going to expect to see some decrease in activity as well, which is why we can see things like sedation are going to be common with these medications. Okay. So there's two ways we can do this, and most of the medications I'm going to mention here will do both. They can either work on postsynaptic alpha-2 receptors, or they can also work on these imidazoline receptors. And we've actually talked about drugs like this before. We've talked about them both in ENT. We talked about nasal vasoconstrictors. We talked about them in ophthalmology when we talked about ocular vasoconstrictors like nefazoline. We also talked about them with, I'm trying to think of the thing, in glaucoma, we talked about aproclonidine and brimonidine. Okay, these are actually doing the same thing. What's interesting is like with the nasal vasoconstrictors, you know, they can work just locally on alpha 1 to cause that constriction to occur. But when taken systemically, with these drugs here we're going to talk about, they work more centrally to decrease outflow of the sympathetic nervous system such that you have that relaxation of the blood vessels, heart rate's going to go down because you have overall less norepinephrine being released from the SNS, right? And so you can see there's a couple of places probably going to work here, which is also why it probably has effects on arousal in terms of like being awake or asleep, because it has effects on in the medulla, for instance, which kind of regulates a lot of activity in terms of like being if you're awake or not, right? And so you can see how this kind of works. So clonidine is sort of like the prototypical agent out of this group here of some central sympatholytics. But you can see overall it's decreasing activity to where it can actually have negative effects on the sympathetic control centers, such you're going to end up seeing less norepinephrine being released, so that can affect the blood vessels and the heart to some degree, and actually end up causing a stimulation of the vagus nerve that can actually end up leading to increased acetylcholine on muscarinic receptors in the heart that slows that down, right? Because remember, there's two ways to slow down heart rate essentially, either to slow it down with acetylcholine or by blocking effects of things like epi and norepinephrine, right? Either one of those can work there. So overall, what we're going to see is a decrease in total peripheral resistance. We're going to see a decrease in heart rate and cardiac output as a result of these effects here. This is the general hemodynamic effects there. Now, some benefits you can see this is that you're not really going to see big things like reflex heart rate increases or anything like that. It also works really well independent of like the age of the patient, their ethnicity, gender. It kind of works for everyone and can actually be used as monotherapy. So you're wondering like, why don't we use this for everyone? Because it doesn't have, it's not probably the most effective, but it could be, useful if the patient had like, contraindications of some of the other first line agents, which I'll talk about in a few minutes, or if, they just wanted to try this out as monotherapy, or if they had some other compelling indications that would lead this to be good. In terms of general side effects, so obviously drowsiness and sedation, these are mainly going to be from the CNS effects, along with a lot of dry mouth seen with this. They also have a lot of sexual dysfunction associated with them because the sympathetic nervous system is really important for a lot of those reflexes to cause erections and ejaculation and all of that. So that can be a big problem for some patients. They have a relatively narrow therapeutic index. It's very easy to overdo it on these medications and lead to some very profound hypotension and bradycardia. Just to give an example what this kind of looks like, I actually had a kid who, 10-month-old, actually came into the peds ER one time and was basically coming in for just not acting right, was very lethargic, blood pressure was kind of low, heart rate was kind of low. They were trying to figure out what was going on. Was it infectious? Was it, did the kid get into something? It's a 10-month-old, so they're active, but not really like, they're not up and walking around by any means yet. And so, they called me to see if it was anything medication related from a tox perspective. And so I went ahead and I was interviewing the parents and I said, okay, well, what medications are you guys on? What medications are in the home that he could have had access to? And the dad's like, well, nothing. He couldn't have gotten access to anything, And I was like, well, what medications do you take anyway? And one of them happened to be, he was on a clonidine patch, and clonidine is one of these central sympatholytics. And so, I was like, well, you know, is there any chance he could have gotten one of these patches? And the guy's like, no, definitely no way he could have gotten into it. And I said, okay. You know, I was like, well, what do you do with the patches when you're done with them? He's like, oh, I throw them in the trash. I said, okay, well, you know, does the kid have any siblings? He's like, yeah, he's got like a 3-year-old brother. I said, okay. You know, I felt like Dr. House coming up with a scenario here, but basically, sometimes what you can see with like young kids is they want to emulate their parents, right? So if they see dad's taking this patch as medicine, makes them feel better. Maybe he wants to give it to his little brother to help out. So I said, well, I think what happened is that somehow the child, either himself or a sibling, ingested this patch. And dad was like, no way, this is impossible. That could have happened. Absolutely not. You're crazy. I said, okay, well, we're admitting the patient anyway. We had him on, there's actually a medication you use, Narcan. If you're familiar with Narcan, you use it for opioid overdoses. It kind of works for clonidine as well. And so we had him on a drip, and it woke him up, and he was feeling, you know, better. Blood pressure was good, heart rate was good. And so I was like, okay, well, in a couple days, just keep an eye on the stool. He's probably going to poop out a patch. And of course, the whole time, Dad's like, no way this is going to happen. Sure enough, 2 days later, the kid pooped out a patch. Felt like a rock star because I was like, this is it. I know what it is. Even though it sounded crazy, it actually is what happened, because kids will do that sort of thing, even when they're not expecting it. So, anywho, back to the point though, is that this is like that clinical picture you can see, especially if you're on higher doses of it. We actually can use it for good purposes though, from this standpoint. So a lot of times, if you have like a mom who is pregnant with a child and they are using things like opioids, for instance, and they're using opioids throughout the pregnancy, when the baby's born, they've been exposed to heroin or fentanyl or, you know, oxycodone, whatever the case may be, the entire pregnancy, potentially. When they come out, they are just as physically dependent on that opioid as the mom is. And so when they get cut off from that, all of a sudden, they have what they call neonatal abstinence syndrome. Good thing it wasn't any stronger for sure. They had, it's called neonatal abstinence syndrome. They are very cranky. They're very irritated. They have things like, you know, issues with blood pressure control and temperature control. They don't feed well because they're withdrawing from these opioids. And so we can actually help out by giving something like clonidine. It helps to really tamp down a lot of that sympathetic outflow they're having from all those withdrawal symptoms, and can help to regulate that a little bit better. So that's something you may see occasionally. If you see a little baby in the NICU on clonidine, it's probably for neonatal abstinence syndrome purposes. The other thing, too, I want to point out is you can have abrupt withdrawal hypertension. This is just the same as you would see with a beta blocker. So you do not want to have abrupt discontinuation of these meds. You have to titrate off of it slowly, okay, if they've been on it chronically. So I mentioned clonidine is sort of the prototypical agent out of this group here. Overall, what you're going to end up finding is this decrease in sympathetic activity, a little bit increase in parasympathetic activity in terms of its effects on the heart. You can see some effects on blood sugar, so you do want to watch out for that. And acutely, you can actually end up seeing a little bit of an increase in blood pressure, but this is not seen for very long. So this will overall not be a clinical issue unless the patient was taking like a whole lot of it, for instance. We can also see some additional benefits in the central nervous system, like decreasing ADH secretion. So we know that's going to help out with things like water retention. Frequently, though, because you're decreasing pressure and that's being sensed by the kidneys, they can respond by trying to increase their sodium retention. So you may oftentimes see this with the diuretics, like HCTZ plus this would be a good combination, for instance. And obviously, sedation is going to be a big issue with this. You can actually get some decent analgesic activity out of this. And so for some of you who go to like work in surgery, if you ever see, for instance, like epidurals being placed for pain management after surgery, you may see like, you know, remifentanil plus clonidine. Clonidine can actually be used intrathecally to help control pain post-operatively, so you may see that occasionally there. So, as I mentioned, withdrawal effects you want to be really cautious with here. You can see some orthostatic hypotension, and then obviously sexual dysfunction and bradycardia can also happen just based off the mechanism like you would see there. Yeah, Alyssa says she saw it all the time in my old job. Are you talking about the neonatal abstinence syndrome or the use for post-op pain? This would be my question there. I was kind of switching gears there pretty quick. Similar to clonidine, you're going to see guanfacine or Tenex. This is actually interesting because not only will you see these drugs being used for blood pressure control, but you'll also see them being used for ADHD. Sometimes these are like second-line agents to a lot of the amphetamines you'll see used for ADHD. They can help to kind of control some of the hyperactive symptoms by kind of slowing down the sympathetic nervous system. So if you ever see like guanfacine extended release, that's called Intuniv. That's used for ADHD most commonly. But here you're going to find guanfacine is used less commonly than clonidine. It's kind of less effective overall, but you'll see some less sedation associated with it. So less effective, so lesser side effects. So maybe good for some patients there. All right, then getting into our direct vasodilators. So these do exactly what they sound like. So they directly cause vasodilation of mostly the arteries. You may see some venous effects as well, as we'll see here in just a little bit. But generally affecting the arteriolar dilation, so direct decrease in TPR. You'll probably see even worse reflex tachycardia with these than even you would with an alpha blocker or a dihydropyridine, for instance. So these are not great by themselves. These are actually pretty crummy antihypertensives by themselves. You should have them on board with something else, like a diuretic or ACE inhibitor or something like that. What you can expect to see is like tachycardia, increased cardiac output, all of that like we saw with some of the other agents we've been talking about. And in fact, because they have such bad reflex mechanisms initiated here, because they're such potent vasodilators, that tachyphylaxis kind of occurs here, because basically you'll just get back up to your baseline blood pressure because the body's resistant to these changes so much. Yeah, NAS is pretty sad. Hopefully, those kids typically do well once they kind of have a good weaning schedule put in place there. But yeah, it's a very unfortunate situation. A lot of social issues that have to be worked out a lot with that too, in addition to having a sick baby essentially. So anyway, we have 3 drugs in this category. We have hydralazine, we have minoxidil, and the nitroprusside are the 3 main ones. You can see here how roughly they're working in terms of their effects on either on the veins, on the arteries. You can see here hydralazine and minoxidil mainly working on the arterioles. Nitroprusside having a bit of a balance here between the two. And again, tachycardia, fluid retention are going to be big with most of these. Nitroprusside a little bit less so. I'll talk about their use cases here. For chronic hypertension, you may see hydralazine and minoxidil being used for this, but they cannot be used for themselves or by themselves. Usually with a diuretic, usually with the beta blocker, something like that, in order to counteract those reflex mechanisms that they induce. Like minoxidil, if I ever see a patient on that for hypertension, they've probably tried everything else under the sun, and this is like the last thing they're able to try. I'll tell you a funny story about minoxidil in just a minute here. Hydralazine you'll see used a little bit more commonly. I see this a lot for sort of like as needed blood pressure control in the hospital because it has IV forms available. You'll see that used for like, blood pressure above, or PRN for blood pressure above whatever value you set, right? And then for hypertensive crisis, this is where nitroprusside really comes into play. You'll see this used in ICUs with some regularity as a direct vasodilator to get blood pressure under control. So if someone was having like, thyrotoxicosis and really high blood pressure, or pheochromocytoma, or cocaine overdose, or whatever the case may be, if you need to get blood pressure down, this is a good agent to do so. So first off with hydralazine, the full mechanism we're not really sure. It probably has something to do with increasing nitric oxide activity within the vascular smooth muscle, maybe interfering with things like calcium movements, but all we know it's a direct vasodilator. The really interesting thing you want to note with this one, because these are some unique sort of side effects, is that first off, in terms of metabolism, it undergoes what they call N-acetylation in the liver. Okay, the reason why I make special mention of this is because there's people who are fast acetylators, and there are people who are slow acetylators. Okay, people who are fast acetylators metabolize it very quickly, and the drug's not super effective for them because they either require really big doses or they're dosing it very frequently. The slow acetylators are the more clinically important ones, because if you put a patient who is a slow acetylator, and again, you can't look at a patient and tell, and there's not a lot of easy blood tests to do, or ones that we do frequently. If you give it to them, they're going to have a hard time metabolizing it. They're going to be slower, and they're more likely to see a lot of these side effects. Okay. The really kind of unique one, and one that I'm going to make a lot of mention here now, is because when you see this, you want to make note of it, because it is something that is easily going to come up on boards. It's going to come up on rotations. Who knows, maybe even come up on a test soon. I have no idea. But regardless, if you have a slow accelerator, they're more likely to see the rebound tachycardia. You're more likely to see dizziness and flushing as a result of the vasodilation effects. This lupus-like syndrome, though, this is the unique point you want to kind of key in on. They can have like a lupus-like rash, a butterfly rash is pretty typical of lupus. That can develop in here. And who are more likely to have that? People who are on long-term use, high dose. Women typically are more susceptible to this. Slow acetylators and Caucasian patients, right? So if you're a white woman with slow acetylating enzymes, you're much more likely to have this lupus-like rash as a result of that. And again, kind of women are more associated with lupus anyway. So it kind of makes some sense. Maybe there's some kind of a common pathway for that. But it's a unique effect, good to kind of make note of, okay? Who are these going to be relatively contraindicated in? Typically people with coronary artery disease, because if you have too much systemic vasodilation, that can kind of limit the amount of blood flow going back to the coronary vessels. It can exacerbate that, causing MI, for instance. You do want to be careful with that. And another point here I want to make note of can actually turn the stools black. Why do we care about that? Well, because if you see black stools, you think about melena, you think about upper GI bleeds, you worry about that, right? Let them know that this is normal. And a key point that I'll make to you now, and I'll probably mention every time it comes up, is that anything that has the ability to change the color of the urine or the stools, you want to warn your patients about, because that is something that can cause a lot of anxiety and a lot of panic in patients if they're not expecting it. If you put a patient on something like rifampin and you don't warn them that the urine's going to turn orange, they could freak out. And I don't blame them, right? Or if they worry about black stool because maybe they're on a blood thinner, you put them on hydralazine and all of a sudden they get black stools, they're going to freak out. Let them know it's okay, it's normal, it's to be expected, okay? Anyway, some funny stories too about urine changes, urine color changes and stuff like that later on I can share at a later date. But anyway, up next we have minoxidil. This is going to be directly opening these potassium channels, and basically by doing that you're kind of effluxing all this potassium out of the vascular smooth muscle, and that hyperpolarizes them, making them very difficult to cause constriction to occur, and so they relax. Okay, so it's kind of a unique mechanism for this one. We would do this for patients who are having really severe hypertension or they're refractory to everything else, but by itself it's a terrible antihypertensive. Not only that, but also because of the potassium effects, you can see arrhythmias. So not great. I wouldn't use it a lot, but I mention it here because we actually don't use it for its antihypertensive purposes mainly. We actually use it a lot for hypertrichosis or to cause hair growth. And so this is one of those things where a side effect actually turned into a new clinical purpose. Just like Latisse, what used to be used for glaucoma, or still is, but can also be used for eyelash growth. Here you can see we can use this to help grow head hair back from patients with like male pattern baldness, for instance. And so that's where the Rogaine actually comes from. So keep in mind though, patients may still have cardiovascular effects. They can still get some absorption and have some issues with that, so you do want to watch out for that. One interesting story I have here is, I don't really have time to tell, but I'm going to tell it anyway. One interesting case was a patient who was an alcoholic, chronic alcohol abuser, and he's homeless and he had run out of alcohol sources, and so he didn't really have a whole lot of options. And so he wandered into like a Walgreens one day, and he's looking around the counters, and he's looking at different medication packages to see what had alcohol in it, because things like NyQuil has some degree of alcohol in it. But we noticed with the minoxidil, the Rogaine actually has a really high alcohol content because it was difficult to get the minoxidil to go into solution. So he said, wow, this is a lot of alcohol in here. I'm going to drink this. So he ended up drinking like an entire bottle of minoxidil in order to get drunk. Needless to say, he was found passed out in the Walgreens. So they called 911 and brought him into the ER. He was profoundly hypotensive. I think in some cases he was getting down into like the 50s over 30s in some cases there. I think we might actually publish a case report about it. I can probably find out. But it was a very severe case. We ended up needing like 4 to 5 vasopressors just to get it actually under control. Let's see, case report. Just to get it under control because it was such a severe ingestion and required just a lot of blood pressure medication to try to get his pressure back up. He survived though, but it was interesting because you saw him come in profoundly hypotensive, profoundly tachycardic as a result of that, right? I'm trying to think what we treat it with. Midodrine. Oh, here we go. Yeah, so this is actually, let me put this up here just real quick to show you so I'm not a liar. So this is a case report we actually did. So I was second author on this. This is actually the fellow who was a year ahead of me. But yeah, we talked about the patient here. Let me see. Yeah, patient presented with a blood pressure of 57 over 48. His pulse actually was still low, so at some points though, he was pretty hypertensive. And you can see here, you got a lot of fluids, had multiple vasopressors just to maintain an adequate arterial pressure, and then eventually ended up using a drug called midodrine to actually get his pressure back up, and that was actually able to keep things under control there. And again, it was like 3 days that he was like profoundly hypotensive, so it was actually a pretty significant ingestion there. So I don't know how much he actually ended up drinking. I don't have access to the PDF. Anyway, so enough of that. Let me get back to the PowerPoint. Just cool cases and cool stories you kind of get. Was it worth it? I don't think he actually thought it was worth it because, I mean, it's not like he actually paid for the hospital bill. You know, he didn't really have any means to do so anyway. But yeah, it was an interesting case regardless. We got a nice little case report out of it. The last drug I'll talk about here is called nitroprusside or Nitropress. This one's actually kind of interesting. It's actually a molecule of nitric oxide, which I mentioned is vasodilatory. And this will make more sense when I talk about nitroglycerin later on. But actually, it's surrounded by 5 cyanide molecules. And most of you are probably thinking like cyanide, that's what like spies use to kill themselves if they get caught by the government. It's the same cyanide, right? So it's kind of interesting though, because it does help to cause activation of cyclic GMP, helps to cause vasodilation both on the veins and the arteries, which is kind of interesting. And this is used for like really significant hypertensive crises, and we use it via continuous infusion to try to kind of dial it in, get the pressure right where we want it to be. It's really good at what it does, but you do have to worry about things like cyanide toxicity, which can lead to things like trembling and convulsions and all of that. So we actually end up giving it with another drug called sodium thiosulfate, and it helps the liver to process cyanide. I mean, cyanide is something you produce in small amounts anyway. I don't know if anyone knows of any fruit that you can get cyanide poisoning from, but there are some that are out there. I'll see if you know it and put it in the chat. But we would actually give this along with sodium thiosulfate to try to prevent a cyanide toxicity, to let the liver process it better, even though then they produce something called thiocyanate, which they can actually, patients with renal failure can actually build up levels and have some issues with it too. But just know that this is the case here. We're going to have nitroprusside be really good for blood pressure management, but you do want to worry about the cyanide issue there. Yeah, so someone said cherry. Yeah, it's actually cherry pits. If you actually chew up the cherry pits, that can lead to some issues. Like really green potatoes can have a different compound in it than cyanide specifically. Yeah, so if you have someone like chews up apple seeds, so Kelly, yeah, the apple seeds, if you chew those up, they can actually cause cyanide poisoning as well. So it's all the same sort of process there. It's called amygdalin, is the product that it gets metabolized in the liver over to cyanide, which is kind of interesting. Actually, I had one guy call the poison center one time, and he actually had eaten a peach pit. Peach pit has it as well, and he was like, "Am I gonna die?" I looked it up, and it has cyanide in it. Am I gonna die? And so I said, "Well, first off, like, how did you eat a peach pit? Like, do you have teeth of steel or something?" But somehow he had done it, and I said, "No, you're probably gonna be fine." Castor beans has ricin in it. Yeah, that's for sure. So. Anyway, so let's talk about hypertension management. Yeah, cherry pits and not this, yeah. So anyway, so looking at hypertension management, this is real quick. You got more details on this in cardio for sure, but I kind of want to make some broad points here. So generally, goal is to get that blood pressure under 130/80. Generally, the lower the better, with some caveats there, and that's going to include patients with like chronic kidney disease and diabetes, because again, those are most at risk for developing diabetic nephropathies and further kidney damage there. In terms of what medications you're going to use as like first line and who you're going to use them in, this really hasn't changed much in the past few years here. But typically, if you're starting out with a black patient with or without diabetes, typically starting off with either a thiazide diuretic or a dihydropyridine calcium channel blocker. So I'll make that mention there, DHP calcium channel blocker. So like amlodipine would be fine, and indapamide would be fine as a thiazide diuretic. Chlorthalidone, I think, has some more evidence showing that's probably the best thiazide-like diuretic to start with. So that's who you want to start with there in the black population. And the non-black population, with or without diabetes, you can start with the thiazide diuretic, calcium channel blocker, ACE inhibitor, ARB, any of those are fine. Most patients will probably end up starting out with an ACE inhibitor, if I had to imagine, especially like most white patients usually end up starting with an ACE and an ARB. If they have chronic kidney disease, though, because you want to try to hold off and try to prevent progression of kidney injury, ACEs and ARBs should be used there, right? If patients cannot tolerate an ACE, then they can move on to an ARB, but I'd probably try to use an ACE first, and if they have cough, then you gotta switch them. So that is what it is. And then you typically see what they do in a month, have them come back in a month. If they're not at goal and you're sure they're taking them, then you can either increase the dose or add a drug from a different category, right? So for instance, I would not use an ACE and an ARB at the same time. The mechanism is too similar. Similarly, I would not use HCTZ plus indapamide. Same mechanism. However, what would make sense to combine together? Maybe like an ACE inhibitor plus HCTZ. Yeah, that makes good sense, right? They have totally different mechanisms. Perhaps we could do something like beta blocker plus amlodipine, dihydropyridine. Makes good sense. We'll find later on that depending on the indications, we'll see what drugs are have to be on board, and that in and of itself might manage the blood pressure. So if they have to be on a beta blocker because they have MI in their history, that can certainly help out with the blood pressure. So some of that stuff's going to be guided by their comorbidities and just specifically what blood pressure medications they need to be on first line. So things like diabetes and heart disease and things like that will make the bigger impact there. So anyway, so let me see if you have any questions on that specifically. Someone said, can patients take aspirin and hydralazine to minimize the flushing side effect from the like they can with niacin? No, they cannot, because it's more of almost like an autoimmune kind of reaction that they're experiencing. Because again, the rash is just like that lupus-like rash you can get there. So you typically think about like the butterfly-like rash can cause that, or it can be kind of the manifestation of that. So it's not the same thing. It's not like prostaglandin synthesis is what's leading to the flushing like you would see with niacin. So that would not be the case there. The best thing it would either be to lower the dose of hydralazine or just use something else if you can. Because if someone like started hydralazine and they presented with that rash, I would have a pretty good idea that they probably are slow acetylator. I would just go ahead and assume that and probably try to switch them over to something else there. Someone said, say you're a 45-year-old white male with no significant history, how would you choose between a thiazide, a CCB, an ACE, and ARB? Is it safe to start with a thiazide? Okay, so you have a 45-year-old male, no significant medical history. I'm assuming he's hypertensive because that's why you're asking the question. It would be safe to start with a thiazide, right? There's nothing that would be apparent off this question that would contraindicate that. However, you want to think about things like, is he sexually active? Is sexual dysfunction going to be a problem for him? The risk for that is higher with something like a thiazide than it may be with something like an ACE or an ARB, for instance, right? If they had, I'm trying to think of any other compelling things there. Could you use amlodipine as first line? Yeah, you probably could, but again, think about things like, do they have a history of like, peripheral edema? Are they on medications that cause constipation? Calcium channel blockers can worsen that, for instance. A lot of little things you have to consider that goes into this. And so think about things like, what are their past medical history, whether, current comorbidities, what medications are they on? Things like that can influence you in terms of deciding which to go with. If you had someone who had hypokalemia, well, something like a thiazide could exacerbate that. Maybe an ACE is a better option in this case because that can actually raise the potassium back up. Or if they have hyperkalemia, an ACE might not be the best option because it's going to raise it further. Maybe a thiazide would be good in that situation there. Okay. All these little things that go into thinking about this, and this is why I'd like to challenge you on tests and things like that with kind of these scenarios, because they make you critically think about it. Yeah, could any of these 4 drugs do it? Probably, but what's the best option based off of the things that we're kind of talking about here, right? Okay, could you use a loop diuretic instead of a thiazide for initial treatment for a black patient with hypertension, or just thiazides? Yeah, do not use loop diuretics for management of hypertension long term. They're just not cut out for it. Remember, loop diuretics are just working there in the loop of Henle to get rid of extra salt and water, and the kidneys are really hesitant to, or are really resistant to that. They will detect low pressure, they'll detect low blood volume, they'll detect low salt, and they will go ahead and increase that renin-angiotensin system and basically make any gains you make in the blood pressure temporary, and it'll go right back to normal, right? Maybe even higher, potentially. So thiazides are better because they help out with a lot of that water logging that you end up seeing in the vessels. They help out a lot with a little bit of phosphodiesterase activity, so it actually helps to dilate vessels there as well. So stick with thiazides for first-line management of blood pressure in terms of diuretics. If they are edematous for whatever reason, and their volume overloaded, and that's what's causing the hypertension, then loops could be useful, but that's not the majority of cases, okay? In CMS, Kelly's saying it was mentioned that ACE inhibitors and ARBs could be a risk for renal failure, particularly in bilateral renal artery stenosis. So in a CKD patient with ACE ARBs are safe. Great question there. Remember we talked about that last time. And again, let me see if I can bring up paint here real quick. If you recall, when we were talking about that, looking at the glomerulus, right? So imagine you have a glomerulus here. You have your filtrate going this direction, and then your blood flow coming out. So the afferent arterial is this direction, blood flow coming in, efferent this way. Remember, angiotensin 2 is causing constriction here on the efferent arterial. This is a terrible arrow. On the efferent arterial heading away from the glomerulus, Ang2 is causing constriction, right? For patients with CKD, they really require that increase in pressure here because it increases pressure in the glomerulus such that more filtrate can be made, right? So if I get rid of this by introducing an ACE inhibitor, so I'm not producing angiotensin 2 anymore, or much less, you're getting less vasoconstrictive effects here. This relieves the pressure in the glomerulus and is going to lead to less filtration occurring, okay? That's why acutely, if you go full blast with the ACE inhibitor in someone who is with chronic kidney disease, especially the worst case it is, you can lead to acute decreases in GFR, right? So acute kidney injury can happen there. We don't want to do that. So again, by using that mantra of start low and go slow, you can help to mitigate that quite significantly, okay? Not going to get too much into like bilateral renal artery stenosis, but just know that this is the typical process here, is that if you relieve that pressure on the efferent arteriole, you lower pressure in the glomerulus and less filtration can't happen, right? This always goes back to like when we talk about interviews and we always ask people, is like, well, did you take physics or not? And then they say, no, I didn't take physics. It wasn't required. We say, well, why do you think it would be helpful? And this is part of the reason why, right? If you understand things like pressure differentials and you understand, some of those basic concepts, it really helps you out in terms of the cardiovascular system, pulmonary system, all of that comes into play here, right? So this is why I really harp on this kind of stuff, because if you understand things like, changing the pressure and how that can affect things like filtration, you're kind of ahead of the game a little bit there. So hopefully that answers your question, but if not, let me know. Okay, let me switch over and go to the next PowerPoint. So this is the last one for this section, so I don't know how much I'm going to be able to get through, but again, if not, we'll do it on Friday. We'll finish it up, and then we will, because I don't have much time left today, but I'll at least get started. And then I'll finish up on Friday, and then I'll likely record that Kahoot, and that way you can kind of go through it with the video. So I'll probably record that tomorrow when we're not meeting, and then I'll post that up for you guys to go through. So not ideal, but it is what it is. So anyway, let's talk about angina. Let's talk about management of this. So remember, ischemic heart disease is basically the oxygen demand by the heart is being, the demand is too high, supply is too low. We're having a breakdown in the economics of oxygen in the heart essentially here. And a lot of this is due to decreased blood flow going to the heart because the vessels are going to be narrowed down due to things like atherosclerosis or blockage due to an embolus or something like that. And of course, when you have this narrowing, right, you're having this ischemic heart disease, that can lead to things like acute coronary syndromes, right? We're still, oh my goodness, I'm so sorry. I always screw this up. My bad, it's up now. Anyway, so when you end up having, yes, I know there's always a delay there with the chat and everything. But anyway, so when you're having these acute coronary syndromes, obviously you can break that down into either like unstable angina, which means like symptoms at rest, right? Or acute MI there. And of course that can be like an NSTEMI, non-NSTEMI, things like that. So, and of course, there's things like sudden cardiac death, which can occur, chronic stable angina. I want to talk mainly about the management of angina. I'll talk about acute coronary syndrome a little bit later. You'll see how the play between these two, because typically patients who have ischemic heart disease with angina progress into things like MI, or they could have MI first and go into angina. But I'll talk about these drugs here, and you'll see kind of a logical flow in terms of this. Oops. So anyway, and again, looking at the balance here between oxygen availability and then the requirements, a lot of it depends on, in terms of oxygen requirements, things like heart rate, contractility, the wall tension that's experienced there versus on the availability side, again, how much oxygen is there in the hemoglobin, right? Are you getting adequate oxygen concentrations? Are you able to extract that oxygen into the coronary circulation, and then how much flow is actually happening here? This is one of the main problems, though, is that we don't have enough flow due to vessel narrowing and things like that, right? So what can we affect here, right? We can talk about affecting things like heart rate. We can affect things like contractility. We can talk about things like wall tension, right? So the actual, wall tension can be affected by things like the ventricular volume and the pressure it's experiencing there. And we'll talk about how we can modify preload and afterload to kind of help take some of the pressure off the heart a little bit, to kind of relieve it such that it's not demanding quite so much oxygen all the time. And that can help to really delay how long it takes for patients to develop anginal symptoms, right? So preload we know to be an issue of typically how much stretching is happening in the cardiac myocytes prior to contraction. And so this is related a lot to things like ventricular and diastolic volume, how much blood's kind of coming back into the ventricles prior to contraction happening there, okay? We'll see some things can affect preload primarily. Some things will affect afterload, or how much pressure the heart has to eject against, and that's mainly going to be our systemic vascular resistance we're focusing on. I mean, it could be other things like coarctation of the aorta and things like that, but mainly we're going to focus on patients who have high systemic vascular resistance and how we can affect the afterload. If we can relieve either of these, that's going to help to decrease the amount of demand the heart's requiring all the time in terms of oxygen, okay? And so we mentioned angina is typically that latent manifestation of ischemia there and can occur really with any degree of stenosis. And even some patients have no stenosis. They have a really spastic coronary vessels. So we'll talk about atypical angina in just a little bit, or prinzmetal angina. That can occur with almost no occlusion of those vessels, right? Typically, though, as you get higher and higher degrees of stenosis, you're going to get less and less flow. Thus, anginal symptoms are more likely to develop even at minimal amounts of activity or at rest, and then it's unstable angina, right? I mentioned the prinzmetal angina. This is frequently due to issues of like autonomic control, where you have things like the autonomic nervous system causing acute vasospasm there, which can cause acute decreases in coronary oxygen delivery, which can manifest as ST segment elevations. It can actually lead to MIs in some cases there. Typically, these are like younger, healthier patients have vasospastic angina. I'll talk about specific drugs we use to treat this and how it's different than what we would use for other cases of angina due to ischemic heart disease, right? So anyway, so what are the risk factors? Obviously, some of these we can fix, some of these we can't. If you have a family history of cardiovascular events, I can't change your genetics, right? At least not currently. Although there is a way we can change genetics. There's actually a cool drug we use for a condition called spinal muscular atrophy. It's actually the most expensive drug in the world right now. It's called Zolgensma. We actually use it at Nemours. We did a lot of the clinical studies. We actually use a modified adenovirus to code for a specific protein that these patients don't make. And so we actually inject DNA into them to produce a new protein. So most of the time, though, I can't really fix patients' genetics. Some things that we can fix. So, for instance, if you can get their diet under control or have them stop smoking and get their hypertension under control and all that kind of stuff, that can be modifiable. Yeah, the drug's really cool. It's like $2 million though for a dose, which is pretty wild. So it's the most expensive drug known to humanity. Anyway, so what's our goals here? So obviously, if we can prevent MIs from occurring, that's going to be beneficial. So prevention of acute coronary syndromes, that's the main goal. And then if we can try to improve their quality of life, not just quantity of life, we can help to relieve symptoms if they're having an acute attack, and then also prevent symptoms from occurring in the future. This is a key thing I want you guys to focus on, is which medications work to relieve acute symptoms and which ones are used to prevent symptoms, because they're used differently. And so you want to know which drugs do which. You don't want to really get them mixed up. Sometimes even the dosage form can change and will lead us to either using them for relief or for prevention. So this is very similar to what we'll see with like treatment of seizures. Some drugs are better for prevention of seizures. Some are better for treatment of acute seizures. Same thing we'll see for migraines, things like that. So keep in mind the difference here. So what can we do to decrease O2 demand? Well, we can do things like decrease heart rate, we can decrease contractility, or we can decrease wall tension by affecting preload and afterload, okay? How do we increase myocardial O2 supply? Well, we can try to improve coronary blood flow. Now, the best way to do that would be to take a stent and open up those vessels, or maybe use a balloon catheterization and get rid of that occlusion. That would be great, but we may not be able to do that with just medications alone, as you'll see. But there are some ways we can help with that blood flow a little bit. And then ideally, if we can stabilize that plaque to prevent ACS, that's going to be beneficial. So this is really where our things like statins come into play, right? You want to think about this as in terms of those pleiotropic effects of statins. This is where it's really important. And then if you can modify those reversible factors, that would be great too, right? But again, changing lifestyle is really tough for patients, and so they may not be able to get all the way themselves. So this is why we introduce medications. So I mentioned revascularization is obviously like the definitive therapy here, but if we can hold off on doing that if possible, that would be fantastic, because obviously surgery has its own issues associated with it, its own risk, and so pharmacotherapy is used for the majority of these patients, as we'll see. First off, we're going to talk about our anti-anginal drugs. So these are either things used to acutely manage an anginal attack or to prevent them from occurring. And then we have our vasculoprotective drugs. And so this is where we're going to see like our statins, ACE inhibitors, and antiplatelet drugs like aspirin are going to come into play. Okay. And then obviously modify the risk factors. So to break them down into their categories, what this is going to fall into, we're going to see that in order to decrease oxygen demand by the heart, we're going to focus on our calcium channel blockers, our nitrates, and our beta blockers. Nitrates will be the new class of drugs we haven't talked about before. To increase coronary blood flow, you can see that things like calcium channel blockers can help out. Nitrates can do this. And then we have some of our antiplatelet drugs like aspirin and your ADP receptor blockers like clopidogrel. So what do our anti-anginals do? They improve exercise capacity. They give the patient more time to do things prior to them developing anginal symptoms, right? Because the heart is either getting more oxygen or not requiring as much, and so they can get her up and go garden or go around their house, whatever they want to do. before they start to have those symptoms there. So exercise tolerance and looking at changes in their activities is going to be a really important way to determine how effective our therapy is. Now, things to help reduce the frequency of symptoms, so these are preventing attacks from occurring, will include our beta blockers, calcium channel blockers, and we can see here either dihydropyridine or non-dihydropyridine can be used here. We'll talk about the differences and how they're used. Then nitrates, okay? I say nitrates, I'm mostly talking about nitroglycerin, if any of you are familiar with that one. So, and again, how you grade it is basically how much activity they can have prior to developing symptoms there. I'm not going to get into having you determine which grade the patient has, which class they have. We'll get into that, but just know that's kind of what we're looking at in terms of efficacy, is where they're at in terms of how much they can do before symptoms start, right? So let's talk about beta blockers first. Notice here they have most of their effects on demand, nothing much on the supply side. They don't really help the heart get any more oxygen, but they do decrease things like heart rate, they decrease contractility, and they can actually help out by decreasing systolic blood pressure. So they help more so out with the afterload than necessarily what they're doing for the preload, right? One of the things you'll find here too is that by giving, especially people who have like LV dysfunction, by giving the heart more time to fill, sometimes that can actually help out with cardiac output. So we can see some benefits in CHF with these patients too, which I kind of mentioned before. So anyway, for patients with angina, for prevention of symptoms, this is going to be first line. As long as they don't have any other contraindications, beta blockers are going to be the first to go with. And remember, how are you going to choose which one to use? Well, if they have CHF, you're going to want to use the three that we talked about: carvedilol, bisoprolol, or metoprolol succinate. If they have a history of asthma, you definitely, or COPD, reactive airway disease, avoid non-selective beta blockers. And if that's the case, use a beta-1 selective one like metoprolol, atenolol. Any of those would be fine in that sort of situation there. So it's not to say you can't use a non-selective one. You just have to be selective about who you use non-selective beta blockers in, right? And so this is going to be good for patients who have a history of like hypertension, if they have anxiety, history of supraventricular arrhythmias, post-MI, heart failure. All these are going to be really good populations for a beta blocker. So this is why we like to use it sort of first line in a lot of situations. Who do we not use it in? Well, if they are already sort of cardiovascularly unstable, so if their heart rate's already less than 60, which is technically bradycardic, if their blood pressure is too low, if they have AV block, or if they're having acute decompensated heart failure, not going to be good for them. Avoid beta blockers in any of these situations. Who to be cautious with, though? Remember, reactive airway disease. So use a beta-1 selective agent there. Systolic heart failure. Remember, typically we're going to start low and go slow with those patients, but I'll talk more about that in detail. I think cardio 4, which will be on the next test. Things like diabetes, because the glucose disequilibrium you can induce there, and then things like peripheral vascular disease. So be cautious here. Maybe start low dose, maybe counsel and things to look out for, things like that. Obviously, the adverse reactions, we've already looked at this. I'm not going to belabor these points here, but be cautious with things like the bradycardia, the hyperglycemia. Remember, you're masking signs of hypoglycemia too. Not just you're raising blood sugar, but you can also mask signs of hypoglycemia too. Remember that more lipophilic drugs are going to cause more CNS effects, right? Things like that. Those are things you want to kind of keep in mind here when you're choosing a drug for a particular patient. Obviously, especially these patients who are having issues with oxygen demand by the heart anyway, avoid rapid discontinuation. This is the thing that could really induce an MI if you were to withdraw this sort of cold turkey. So you do want to be cautious there, right? Make sure patients know they need to keep taking it. If they go on vacation and they forget their meds at home, they need to get a source, right? And again, most pharmacies will have a provision where they can at least get a 3-day supply, or they can call your office and get a new script, whatever the case may be. Because again, there's certain medications we don't want patients to go without because it can be quite deadly, right? I don't want a type 1 diabetic to go without insulin, just like I don't want someone who's been chronically on a beta blocker for angina to go without a beta blocker. I don't want to be responsible for that patient's death, right? Anyway, moving on, then we have our calcium channel blockers, and it's important to keep in mind the distinctions between these two here, how the DHPs work differently than our non-DHPs. Remember, DHPs can actually increase heart rate, which actually sounds like a bad thing for angina, but we'll look at how we use this. Non-DHPs will lower heart rate. Contractility is generally going to go down for non-DHPs. It's probably not going to change for dihydropyridines. And then overall systolic blood pressure is going to go down. And you might have some decreases in LV volume. This is more due to some venodilation, but it's mainly going to be on the afterload is where the calcium channel blockers will have their biggest effect here. Now, in terms of supply side, there is a little bit of help here. So you can see some coronary vasodilation occur here, but it's minimal, right? May be helpful in certain areas of stenosis, but actually where it's really helpful, especially with the dihydropyridines like amlodipine and things like that, are good for relief of vasospasm. So this is going to be really good for that Prince metal angina, and actually calcium channel blockers, the DHP specifically, are kind of your go-to for Prince metal angina. There's a little key point there. So how you would actually break these down, and this makes sense based off of what we already talked about. The dihydropyridines are going to have much better ability at causing vasodilation, but they're not really going to have as much effect on contractility, very minimal effect, and you're going to see that if anything, they may raise heart rate, and they won't do anything to conduction, right? Versus the non-dihydropyridines will have some vasodilation, not quite as strong as the DEHPs, but they will decrease contractility, heart rate, and AV conduction, okay? Again, do I care if you know it's a 2 arrow down or 1 arrow down? No, just know the general flavor of these, I should say, So how do we use these? So if a patient couldn't take a beta blocker for whatever reason, or it's not tolerated, they just didn't like the side effects, whatever, you could use a non-DHP as an alternative. So if they tried metoprolol, didn't work out for them, they could use verapamil or ditizum as an alternative to that. So they're not first line, but they could be second line in that case there. Or if a patient's on a beta blocker, but maybe they're not getting enough symptom relief, or their anginal attacks are too frequent, this is where you can add on a DHP to a beta blocker, okay? Remember, non-DHPs and beta blockers don't mix. Don't do that. You can use one or the other. When it comes to dihydropyridines, you can use that in addition to a beta blocker, and that makes sense, right? Because think about where they're working. DHPs are working more on the vessels, beta blockers working on the heart. Non-DHPs also work on the heart, so you don't want to mix those two up. It'd be too much, okay? Oxygen demand will go down, but it might go down so much that your patient can't actually maintain consciousness anymore, which would not be great. Or you could use these in combination with long-acting nitrates, and we'll talk more about those in detail in just a few minutes here. In terms of contraindications, or who you're going to use this in, basically people who cannot tolerate beta blockers, or maybe beta blockers have not been sufficient on their own. They have vasospastic angina. This is mainly going to be like the DHP specifically there. If they have severe peripheral vascular disease, asthma, diabetes, these are okay agents to use for these patients here. But it's not really like a slam dunk for any of them. So usually it's either an alternative or an add-on medication for patients with angina, okay? So as I mentioned, non-DHP may be initial therapy as an alternative to a beta blocker, or DHPs in addition to a beta blocker, okay? And typically we don't like to use short-acting agents like nifedipine, mainly because it can cause kind of too big of a drop in blood pressure. By doing that, that causes that reflex tachycardia, which may lead to increased oxygen demand and anginal symptoms. So you want to avoid that, okay? All right, contraindications. If their blood pressure is too low, don't use it, right? If their heart rate is too low, this will be an issue with the non-DHPs only, okay? Or if they have acute heart failure, this is not great too, because you're going to depress that LV function even further, and that can lead to an exacerbation. So generally speaking, non-DHPs and CHF don't really mix very well, right? You see, you can lower their ejection fraction as well. Not great. Be aware of the drug interactions too. Remember that the DHPs are going to be substrates to CYP3A4, whereas non-DHPs are going to be inhibitors and substrates to 3A4. So we want to be cautious with that as well. In terms of adverse reactions, we talked about these before. Things like a lot of hypotension, flushing, constipation is a big one you're going to see with this. Worsened peripheral edema, especially with the DHPs, you can see that for sure. And in terms of monitoring, again, looking for symptoms, have them keep a diary of how often they're having symptoms come up, and look at the heart rate for the non-DHPs there. And obviously let them know about things like dizziness and constipation are going to be common adverse effects. All right, now let's get into the nitrates with the last few minutes I have here. So nitrates, if anything, you're going to find that they are really good at causing vasodilation. They work on both the arteries and on the veins to do so. So they have a nice balance between these two here. And so this is good because it can help to reduce afterload and help with preload as well, which is beneficial. Basically, the veins are going to be more dilated so they can hold more blood on that side. So you have less volume coming back into the heart. So that helps to decrease that wall tension there. Overall, oxygen demand is going to go down, right? Heart rate can go up a little bit, and that's mainly due to the vasodilatory effects. So kind of think about it like a DHP in that situation there. They just have stronger effects on the venous side of things, okay? Now, on the supply side, this is really important for these drugs here. This is a really helpful effect. This is what's going to be used for the acute treatment of anginal symptoms here, right? Because these are not only used for prevention, but these are also used for treatment of acute attacks. because they dilate the coronary arteries and they relieve that vasospasm. So if a patient's having chest pain, this is what they're going to take when that occurs. Okay. They also have some antithrombotic effects, which can be beneficial as well. How do they work? Well, basically, nitrates are going to provide nitric oxide. Nitric oxide is going to get into those coronary vessels, get into the vascular endothelium. It's going to help to increase amounts of cyclic GMP being formed here. Cyclic GMP is then going to cause decreases in cytosolic calcium, and less calcium coming into the cell means less constriction. So you get smooth muscle relaxation, you get vasodilation, and blood pressure goes down. Okay. Now, obviously, this has to be regulated, right? You don't want to have too much vasodilation because that could lead to syncope, it could lead to profound hypotension. You don't want to do that. How is this regulated? Well, it's going to be regulated by breakdown of cyclic GMP. If you get rid of that, then the rest of this cascade does not occur here. The enzyme that does this is called phosphodiesterase, and there's different flavors of it, but PDE5 is the main one we're going to focus on here. So PDE5 helps to prevent breakdown, or I'm sorry, PDE5 normally breaks down cyclic GMP. There are some medications that can prevent PDE5 from working, right? So when we talk about sildenafil, tadalafil, and vardenafil, this is going to be important. We talk about our medications for erectile dysfunction. This is going to be a major, major drug interaction that occurs if you take these along with nitrates. And so keep that in mind. We'll probably have to talk about this next time, but think about that interaction. Keep it in your mind that when we talk about it, it's a really important one, okay? So looking at short-acting nitrates, these are good for acute treatment of anginal symptoms here. I thought I had a background on me, but it's just this picture of nitroglycerin behind my head. So this treats acute symptoms of myocardial ischemia. It also can prevent some effort-induced angina. If the patients know they're going to be a little more active, they can take a nitroglycerin almost as a preventative in those cases there. Now, how you use it, it depends if you want to use it as a sublingual tablet. Some people use it as a sublingual spray. Note that by using those routes, it helps to prevent first-pass metabolism. These are not swallowed. These are just placed underneath the tongue, and they absorb. That bypasses first pass, and they work much more effectively. So what do? We will dose this every 5 minutes until they either have relief or EMS arrives. And the way we used to do it is that patients would take it every 5 minutes, and if by the third dose that it didn't work, and then they would call 911. Nowadays, we tell them, hey, if you don't have relief in 5 minutes after the first dose, continue taking every 5 minutes, but after that first dose, call 911. Because when it comes to ischemic heart disease, time is tissue, and so we want to have patients getting assessed earlier to get the EKG hooked up to see if it's something that is really concerning or not. So that's why they have them call earlier, right? And so when taking these, you have to be really careful. Warn about orthostatic hypotension because, again, this is the major side effect. Have to make sure if they're going from sitting to standing that they can really get a lot of dizziness and can have a syncopal episode as a result of using these short-acting nitrates. Remember, the shorter acting the med is, the bigger peak effect it has, which means you can get more of that hypotension developing there. It's really important for the tablets that we store them in the original packaging in a cool and dry place. I'm like, why am I mentioning that now? Because notice here in this little amber vial, this has to be airtight because nitroglycerin itself is very unstable. If it's exposed to air, it'll start to break down. And so if you have a patient who moves their nitroglycerin tablets to like a little pill minder, you will find that they can break down and they take them and they're like, oh, my chest pain is not going away. It could just be because the medication is not that effective anymore. We'll have them actually come in and get a new refill that at least every 3 to 6 months or so just to prevent that breakdown from occurring. Say in the back of the ambulance, you have to be careful of the spray when priming the pump, since it could get blown into your face by the AC unit. Interesting. I did not think about that. Yeah, and so there's certainly some other cases of healthcare providers being exposed to nitroglycerin, some effects you can get from that. Maybe you got a nice little headache or something when that was occurring, huh? Anyway, make sure they're doing it underneath the tongue and not trying to swallow it because it will not work quite as well there, okay? All right, I only got about 3 minutes. I want to take a few minutes for myself between now and EpiBios. I'm going to go ahead and cut it off there. We'll talk about long-acting next time. Our sprays were mint, which is helpful in many patients. Interesting. Let's have a nice fresh breath. When they come into the ER, you find a lot of patients do not have that, and that can be a bit of a bummer if you have to get real close in with